أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. On today we want to discuss actually one important aspect of the disease, and that is rheumatic fever, acute rheumatic fever. Right. The scenario will be presented in front of you. Scenario is presented in front of you, and it is related with the case related with the commonest presentation of the disease. So I will start with this a slideshow, and this is a classical type of the show, which is often very common presentation. I summarize in my own way. Now, this is the presentation, and I'm presenting this case as this one. Now, report this ECG. This patient admitted with a paralytic ileus. Hypokalemia changes are seen in this electrocardiogram. There is T wave flattening and prolonged QT interval. However, the changes of hypokalemia will be more is that the T wave inversion can occur, ST depression can occur, and a wave that is the present of the U wave. Now, U wave is here. This is a U wave. Classical U wave present. The U wave are the features, one of the features of severe hypokalemia. As far as hyperkalemia is concerned, P wave are flattened here. They are tall peak waves, hyperacute T waves. While QT interval is not much disturbed, QR's interval is increased, PR interval is increased. These are the features of hyperkalemia. The balance one on the P side and one on the T side, and T will be affected more, it's higher, while P will go down. In hypokalemia, opposite occurs. P will be down and down and down, and so flattening occurs, even T wave inversion occurs. This is how the balance works in hyperkalemia or hypokalemia is concerned. I start with Professor Sayyid Ali that I am presenting this case, something about the fever with arthritis. Scenario is that a 15-year-old girl was experiencing high-grade fever for the last 6 days. She noticed severe pain in the right knee followed by redness and swelling since last 3 days. She arrived in the OPD with a central chest pain, okay, and accentuated on inspiration. On examination, temperature was 101 degree, pulse was 117, tachycardia, the BP was 100 by 67, knee was red and swollen with the restricted movements. A harsh scratch sound heard at the sixth intercostal space on the left side of the anterior axillary line. It is most probably accentuated on pressing the stethoscope. The underlying diagnosis will be pericarditis it is the classical presentation, clinical examination of the pericarditis, acute fibrinous pericarditis. On investigation, hemoglobin was 12.7 and TLC was 13,200, platelet was 438,000 and ESR was 58. Random blood sugar was 78, while X-ray knee, swollen and periarticular tissues. Now here, if we drag the questions, differential diagnosis, how will you further investigate? Most likely diagnosis, how will you manage? Drag soft data and drag hard data. Hard data is that a girl of young age suffering from fever, she has evidence of the chest pain in the form of the pericarditis, which clinically we have detected it, and there are acute phase reactions which are increased, thrombocytosis, leukocytosis, ESR. This is acute inflammation is going on in this lady. Differential diagnosis is manifold. Post-streptococcal reactive arthritis. It is non or seronegative arthritis and is non-migratory. In rheumatic fever, migratory, migratory polyarthritis is seen, fleeting in nature. Rheumatoid arthritis, SLE, infective endocarditis, sickle cell disease, drug reaction, TB, and COX, and Lyme disease and serum sickness. The most likely diagnosis which I will make here with the help of the hard data should be acute rheumatic fever. So I will apply my knowledge of Jones criteria modified. Two major and one minor, two major criteria or one major or two minor criteria is needed. Major criteria is carditis. Carditis here means pancarditis, pericardium, myocardium, and endocardium are involved. If the one is there, it means that it is carditis. Polyarthritis, it is fleeting in nature, always migratory in most of the cases. In 40% of cases, it is non-migratory. Chorea is there, which is called Syndam's chorea, erythema marginatum, and subcutaneous nodules, which you will see in the slides. The minor criteria will be the fever and arthralgia clinical, and lab findings here, the acute phase reaction will be increased, like ESR, C-reactive protein, leukocytosis, and prolonged PR interval, and you have also echocardiographic changes is added now in 2020. New criteria, Jones double modified criteria. So one major and two minor criteria should be have got evidence of the antecedent group A streptococcal infection. Otherwise, you will not able to diagnose rheumatic fever. In our country, the positive throat culture or you will do ASO titer, which are commonly used here, investigation. Otherwise, other investigation are anti-DNase antibody or anti-hyaluronidase antibody, which is not available in this part of the world. One major, two minor, or two major criteria is needed to diagnose it. It is a streptococcal A infection actually, which occurs 3 weeks before, and it will attack on the target tissues, the joints, the heart, the skin, and the nervous system. It is not very common now in developed countries at all. It is hardly 10, 100,000. When in our developing countries, it is about 100 per 100,000. Now it is gradually reducing because of the knowledge we are providing to the people, hygiene, etc. So mostly the children are involved. The inflammation occurs and wane off. After many years, they develop the heart disease. This is the hallmark of the problem of the rheumatic fever. Actually, it is the hypersensitivity type 4 reaction. The portal of entry is pharynx always, or tonsillar fossa, and then the antibodies are produced in the body. Humoral type of the antibodies against these polysaccharide protein complex antigens, etc. And many types of antibodies are present. Anti-Hollandaise, anti-Fala, it is hypersensitivity type 4 reaction, autoimmune phenomenon. That is why it is actually written in the autoimmune diseases in Harrison textbook of medicine. It is described as autoimmune phenomenon. It is a delayed reaction. Definitely, I said already, it is a delayed type of reaction. Not the clinical features of the heart disease will come after many years. These are the antigens which are written here. O antigens, hydrolase, streptokinase, etc. DNAs, there are four more. These are the post-mortem findings which are where you see here the heart is involved, very valvular region are involved, endocarditis. The commonest presentation are the arthritis and followed by the others, whether they are associated with the heart disease or not. Now, this is how we manage this case. Clinical manifestation of carditis actually is the new heart murmur, cardiomegaly, pericardial frictional rub. Chronic inflammatory changes will be chronic rheumatic heart disease as a valvular disease. Now, characteristic murmur of the heart disease may be mid-diastolic flow murmur, present which is called as Kericum's murmur, or AR murmur may be heard. You can also get the AV conduction delays. These are the post-mortem findings of these cases, carditis. Radiological findings, cardiomegaly, patient goes into the failure, pulmonary edema. And these are the pictures you see here. Primarily, the PR interval is increased. Normally, it's 0.18 second. Here it is 0.24, 0.22 second. It can lead to the third degree heart block, complete heart block. You see here severe bradycardia with the AV dissociation. Arthralgia and arthritis may be migratory and warm swollen tender joints, usually involving the knees, ankles, elbows, and wrists. Last 2 to 3 weeks. Joints polyarthritis and it is migratory arthritis, more chances of heart disease are there rather than skin manifestations or rather CNS manifestations are concerned. Levis response are seen in the knee joint or any joint. That is tenderness, pain, hot, and unable to move. These are it's called Levis response. Subcutaneous nodules occurs, painless nodules at the pressure points. They are different than the other ones. These are the subcutaneous nodules. Erythema nodosum and another one with nodular condition occurring in other diseases of autoimmune nature, SLE for example. But they are tender type of a nodosum rather than non-tender. Only the lower limbs are involved in erythema nodosum, while here it is the peripheral parts, limbs, upper limbs, backs, they are involved in cases of the subcutaneous nodules. Skin lesions are the erythema marginatum rather than that non-pruritic type of lesion. It is you can see it has got a background of rounded shape and center is pale and in between there is slight redness. It is a major criteria and there is a sign of the disease. This is the microscopic picture of it. Neurological involvement occurs because of the vasculitis actually. It is the uncoordinated purposeless movements which occurs and it lasts for 2 to 4 months. Because it lasts for a month, then you have got chance of the prevention, secondary prevention. So these cases are not manifested with the least chances actually for the heart disease is concerned. Because of the late appearance and because of the sustained for 4 months. St. Anne's Korea. Here is a picture of a child, the mothers actually observing the child that the child is actually is acting, purposefully acting. It's not purposefully acting, it is purposeless. According to the mother, actually, he wants something from the mother. So this is not actually the imposed person. Imposed me. This is not imposed. There are other causes of chorea as well. Huntington's chorea and drug-induced chorea and autoimmune diseases, etc. Jones criteria already described by me, major criteria and minor criteria. Two major, one major and two minor, plus the recent evidence of the streptococcal infection. This is how we diagnose this case, in most of them. If you remember this, I hope this short summary of mine will helpful to you as far as this is concerned. This is the end of the session 1. And we will go for the end of the session, the other session.